So welcome to Managing Smoker and Lung Cancer Treatment, the clinical and pharmacotherapy implications tonight. So I'll just go to my talk here. Everyone tells me this is going to work. So I'm a respiratory physician by trade. I work at Fiona Stanley Hospital. But I'm also, I work with the WA Cancer and Palliative Care Network as a thoracic tumour collaborative and have an affiliation with UWA. And I just would like to start by acknowledging the traditional owners of the land, the Noongar Whadjuk people. I would like to pay respect to the elders past and present and offer my acknowledgement and respect to other Aboriginal and Torres Strait Islanders who are present. And I'm just going to go back up there. And I'd like to also extend a special welcome to all of you here tonight joining us. I don't think we have our video conferencing people dialing in at this stage. We had a few people dialing in, but it doesn't seem like they have. So we're really hoping that tonight's seminar and discussion will ignite our drive to get smoking cessation policy back on the agenda at our hospitals where we work, and ultimately try and improve our practice to ensure that smoking cessation is built into the journey for our lung cancer patients. Today's event is thanks to Cancer Council WA, collaborating with the WA Clinical Oncology Group, the WA Cancer and Palliative Care Network and the Thoracic Tumour Collaborative and St John and Guy Subi. And also Ashley Reid, the CEO of Cancer Council WA, can't attend this evening due to apologies. Just before we start, a couple of housekeeping points. We don't have our video conferencing people, so that's okay. This is being recorded by Telehealth, this session. And we're going to have all our questions at the end. We're going to, so just hold your questions to the end and we'll have a panel discussion up here. And all, a small groups with all chat. So hold your questions until that time. So why are we talking about smoking cessation in the setting of lung cancer? Well, as a respiratory physician, I probably see we're often the first point of call for those coming into the hospital. And I know that we don't do a particularly good job of talking about smoking cessation. There are a number of reasons. Smoking remains the most common contributing factor to lung cancer. And at the time of diagnosis in the literature, about 24 to 60% of patients diagnosed with lung cancer smoke. In the last couple of years, our nursing staff at Sir Charles Gairdner Hospital and at Fiona Stanley Hospital, we did an audit and discovered, just to look at the smoking status of our new lung cancer diagnosis presented in June, we found quite a lot of difference north and south of the river. At Fiona Stanley, 60% of patients we see and diagnosed are current smokers. At Royal Perth, it's about 50%. And at Sir Charles Gairdner, it's about 30%. So quite a wide range just in the Perth metropolitan area. And that kind of sparked our interest in looking at this topic and trying to do a better job. So one of the issues we're going to discuss tonight and we want to clarify is what are the benefits of quitting or smoking cessation once the diagnosis of lung cancer is made in the patient's journey at different time points. What is the evidence for the patient who's undergoing surgery or undergoing chemoradiation therapy? And how do we then best incorporate smoking cessation into our clinical practice in our busy days, in our busy clinics? During this evening, we're going to hear from Emma Dean, who's here from the Alfred Health. She's going to provide us an overview of best practice approaches and how to embed smoking cessation in the hospital setting, and present evidence on how to use brief interventions to all patients with cancer who smoke, and information on pharmacotherapies. Now, just a bit of an introduction before we go forward. This is a study published a few years ago by the International Association for the Study of Lung Cancer, ISLAC. And they looked at over 1,000 people, or doctors really, in many different countries, Europe, US, Japan, and how did they talk about smoking cessation with the patients who had lung cancer. And they looked at, and this is across many countries. Most of the people who responded were doctors, about 87%, and they worked in university or academic hospitals, which is where most people initially with lung cancer are often seen and diagnosed. And what we know, and this looked at practice perceptions in the respondents and what they did in their practice. So most people asked their patients, most of the clinicians asked their patients if they smoked and if they were planning to quit, and they advised them to stop. But only a few actually less than 50% discussed medication options or came up with a a cessation plan or actively treated or referred those patients for smoking cessation. Is that a video conferencing bell? Hello, whoever's dialed in. Now we looked at, and then they looked at different, I tried to clarify what were the barriers to providing smoking cessation support for cancer patients. This is cancer overall, not just lung cancer. And you can see here with the asterisks, I don't know if my little mouse will work, the factors associated with decreased cessation support for patients were I've got inadequate training, or I don't have the experience. This is on the part of the clinician, and that they need more training to feel confident in offering their patients smoking support. Also, they have lack of time. I mean, in 45 minutes I have to see a new patient, tell them they've likely got lung cancer, get there, talk about the procedures that we need to do informed consent, and organise all the bookings and tests, etc. in 45 minutes. To incorporate smoking cessation into that as well is impossible. So I can certainly understand the lack of time for counselling or to set up a referral. And the other issue is lack of available resources at their centre for referrals or cessation interventions. And these factors that are highlighted are the ones that were associated with decreased support. People still raised it with their patients, but they didn't do much about it. So providing clinician education and dedicated cessation resources may be the highest yield target to optimally improve smoking cessation for lung cancer patients. And this is not just amongst the passionate few in this room. This is internationally. This topic is very controversial, and there's a lot of discussion going on. These are two commentaries in the Journal of Thoracic Oncology in the last few months. The first commentary was by Friedrich Stiefel, who is a psychiatric liaison, part of the psychiatric liaison team in Switzerland at Lausanne Hospital, and basically wrote a commentary that these teachable moments or interventions for smoking cessation are actually stigmatising patients with lung cancer and could be doing harm. And his quote was, teachable moment interventions is not sane. It is up to the patient to indicate if and when he is motivated to initiate possible modifications of lifestyle to achieve health-protecting behaviours. And we should just stop trying to do this because we're doing harm and stigmatising lung cancer patients further. So that was quite a controversial statement. And this was responded to by Carolyn Dresler, who chairs the ISLAC Tobacco Control and Smoking Cessation Committee, who wrote very strongly against his commentary and said, of course we must not stigmatise or criticise patients who continue to smoke, but failure to address tobacco cessation in any patient with cancer means failure to capture a major therapeutic opportunity and is, in our view, unethical. And clinicians who ignore the impact of continuing smoking must recognise they are working against evidence-based practice. So pretty strong comments. On that note, I'm going to introduce our speakers. So we have a number of speakers tonight who are going to... Oh yes, just to our video conferencing colleagues, if you can, just a little housekeeping note, if you're able to mute your audio and unmute at question time, that would be great, just so we don't get any feedback. So to our speakers today, they're going to give a very succinct synopsis of, which is very hard to say quickly, of what's happening in their space. And this is a patient's lung cancer journey through the hospital. Remember, most of it's going to be in a tertiary or secondary hospital, and they meet many different people in their multidisciplinary team, and we all have a different role to play, and they meet us at different time points. So our first, these are our speakers, and our first speaker is Ms. Ziwan Lee. Who is a clinical nurse consultant at Fiona Stanley Hospital. And I'm just going to go down to your talk. And who I work with in the respiratory department. And she's going to focus on what's happening at Fiona Stanley Hospital and how she is trying to address smoking cessation lung cancer patients. Thanks, Ziwan.
Thanks, Annette.
Oh, and everyone has 5 minutes. I'll time you. I'll come up with my
Thanks, Annette. A bit of stress. So nice to see you everyone here tonight. So I run a smoking cessation clinic in Fiona Stanley Hospital. I see, other than lung cancer patients, I also see asthma, COPD, and pleural conditions and all sorts of respiratory conditions. But for today, I'm focusing on the lung cancer patients only. So like Annette said, we have a large proportion of new cancer diagnoses who are current smokers. So we started the smoking cessation clinic as a quality project for 12 months. So April last year, that's when we started. Basically how it runs is I see patients in clinic for the initial assessment and education. With their follow-ups, depends on their preference. It can be face-to-face clinic appointments or telephone calls. Like some people, if they're remote, then I'll do telephone follow-ups. If there is pharmacotherapy involved, then I get support from the respiratory consult team. So what do I do? So in terms of assessment, I go through a nicotine dependence. So I use the Fagerstrom test that's strongly supported by evidence. And I asked about their smoking history, and I asked about their feeling about smoking. What do they like about smoking? What don't they like about smoking? So get a good understanding of their smoking behaviors. Then we identify the situational triggers and the barriers to quitting together. And I encourage patients to elaborate on their past quitting experiences, whether it was successful or it was unsuccessful. And there was always a lot to learn from that. And then we go through their withdrawal symptoms, and I always do a carbon monoxide reading. In terms of additional information, I always do a weight. I go through medical history, mental health history, current medications, and the other recreational drugs if they are not already documented. In terms of education, so we talk about the nicotine and the magic that nicotine does in the brain. And I also give information on nicotine dependence from the physical perspective, also from the psychological perspective. And I explain the different chemicals in cigarettes to patients. Carbon monoxide, I interpret the reading with the patients, just so it's a visual tool for them to see. And I explain that little competition in between carbon monoxide and oxygen in the body, and that's usually quite useful. And I explain the health effects of cigarette smoking on different body systems, not only respiratory, particularly from a lung cancer perspective, of course. And we talk about benefits of quitting from a health, financial, and independence perspective. Then I offer suggestions to strategies to deal with withdrawal symptoms, because a lot of them are scared of the withdrawal symptoms. And I also recommend different sort of relapse prevention, depends on what habit links that they have. So looking at the results, so these results are only, I'm talking about the referrals from the lung cancer clinics. So from April 2017 to the end of the year, I got 10 referrals and they were all from respiratory physicians. And 5 of those patients achieved complete smoking cessation. And I have to say one of them was by cold turkey. And 4 other patients reduced the number of cigarettes very significantly, but they couldn't manage quitting. Not everyone could quit, but again, we can try again later. And there's one I can't get hold of. So from the beginning of this year to April 2018, I received 9 referrals. There was one never wanted to see me in the first place, and the other... Thanks. And the other 8 patients are still in follow-up, and out of those 8 patients, 2 have recently quit in the last 4 to 6 weeks, and 2 have reduced the number of cigarettes significantly to under 5. I guess looking at the results, they personally is quite encouraging, and it really helps me with my confidence, but the number is very small. So I guess we could see hundreds of patients throughout our clinic a year, but 19 patients a year is very small. But I guess the next step for me is to expand the clinic, and I want to encourage everyone in the MDT, all my colleagues, to help me identify those moments, the window of opportunity, so we can help the patient to achieve the goal eventually. So referrals welcome. Thank you.
Keeping to time. Thank you. Thank you, Ziwan. This was a pilot project, so I think that's important to state, and we'll expand from there. So our next speaker, I'll just go to, is Dr. Hamish Mace, is a Fiona Stanley Hospital anaesthetist, and he will talk about smoking cessation in the perioperative setting for lung cancer patients. Thanks, Hamish.
Thank you. Thanks very much, everyone. So as Annette said, I'm an anaesthetist at Fiona Stanley. I'm also the lead clinician in the Fiona Stanley Perioperative Smoking Cessation Clinic, which we've just started collecting patients last week. Why are we worried about smoking in surgery? Well, smoking is a major public health problem, but it's also a major problem around the time of having an operation. Here's a large retrospective study of 600,000 American surgical patients. The chance of having a pulmonary complication was double in patients who smoked and continued to have surgery. Cardiovascular complications were increased by anywhere from 70 to 80%. And most importantly, I think, infections. So infections were increased not only in the wound, but also deep in the organ space, and septic shock by 30 to 40%. And probably most important of all, smokers are more likely to die at 30 days, well, within 30 days after surgery, with an increase of 40%. There seemed to be a dose-dependent relationship here as well, with the amount of pack years smoked correlating with the risk of complications. And why is that? Well, as we heard before, carbon monoxide competes with oxygen at the hemoglobin molecule. That reduces the amount of oxygen being delivered to the tissues. As well, it left shifts the oxyhemoglobin dissociation curve, which means oxygen is unloaded less from that hemoglobin as well. Coupled with that, nicotine causes sympathetic activation, which leads to vasoconstriction, and coupled with increased myocardial work from increased rate and rhythm, leads to an ischemic milieu in both in the tissues and in the heart. I think Josh is going to talk to you a little bit about wound healing, but that's one of the major complications that we're worried about smoking in surgery. I wanted to go into something I'm a little bit more familiar with, and that's pain. Now, I wish I had heaps of time to talk about this, because I find this really, really interesting. There's a very, very strong association with pain and cigarette smoking, not only in the chronic pain patients, but also in the acute pain space as well. They have higher pain scores perioperatively, they use higher amounts of opioids, and they suffer more from pain. And why is that? Well, there's multiple purported mechanisms for this, but one of the most important ones is enzyme induction from cigarette smoking. The enzyme induction leads to rapid metabolism of the opioid medications that we use for pain therapy and a reduction in plasma levels of opiates. So that's very interesting, I thought. Also, there's a lot of crossover between chronic pain and acute pain. Now, we know that there's a strong association between chronic pain syndromes and acute perioperative pain particularly. So patients who are smokers tend to have higher rates of chronic pain and tend to have more disability related to their chronic pain as well. And what I thought was really interesting when I started looking at this was nicotine actually acts as an analgesic, and there have been studies looking at the use of nicotine perioperatively. It seems to work reasonably well in non-smokers, with the major side effect obviously of having severe nausea. Chronic smokers do not get as much of an effect from the nicotine perioperatively, probably because their receptors are downregulated. And there seems to be a major crossover with the indigenous opioid syndrome system as well. Fortunately, surgery is a very, very teachable moment in smoking cessation. In all those patients having major surgery, it doubled the chance of success from a quitting episode. This is a major database review of 35,000 American surgical patients, 35,000 American retirees again. Having major surgery was twice as likely to lead you to have a quit event. 1 in 10 quit events in all these patients related to surgery. So I thought that's a very, very useful time for us to introduce the smoking cessation conversation. And what's more, smoking cessation was very effective post-operatively as well, not only in assisting patients to quit, but also reducing all-cause complications. So the chance of having a complication in this other large series here was reduced by 45%, with wound complications and pulmonary complications featuring prominently. Now, what works for smoking cessation perioperatively? Steed in his Cochrane database review recently showed that health institution-led behavioural programs, such as the one at the Alfred, such as the one that we're starting at Fiona Stanley, were very, very effective compared to usual care. Not surprisingly, more intensive interventions, for instance, including comprehensive counselling, nicotine replacement therapy, and brief intervention at all levels of the patient care, were very successful, much more successful than brief interventions. For short-term smoking cessation success, there was a 10-fold increase in success in patients having intensive interventions. That correlated to long-term cessation rates of about 3-fold. brief interventions seem to have a short-term benefit, but probably not as good a long-term benefit as we would have liked. With regards to telephone counselling, one small study looked at telephone counselling in addition to NRT and showed it was very successful with a number needed to treat of about 6. I think this particular point is very useful for us as well because we're following a model of telephone counselling for our patients, both in the immediate preoperative space and also post-operatively as well. Now, nicotine is a little bit contentious perioperatively. Some surgeons are completely paranoid, particularly plastic surgeons as well, because they feel that the vasoconstriction, afforded by nicotine is probably outweighs the vasoconstriction, so the benefit is outweighed by the vasoconstrictive effects. However, nicotine as part of a comprehensive strategy increases abstinence rates by about 60%. The plasma levels of nicotine are much lower, and in fact, there's thought to be no effect whatsoever on wound perfusion or healing, and certainly no effect on a flat perfusion in plastic surgery. There's also no effect long-term on bone healing and no cardiovascular risk from nicotine replacement, so I think that's very important. With regards to optimal timing before surgery, obviously we know the earlier you can start the better, but even stopping in the immediate weeks before surgery is very useful. Hemostatic function improves within 7 to 14 days. Pulmonary complications start to improve at about the 4-week mark, and wound complications get better at about 3 weeks, and that's probably as the immune changes start to reduce. And lastly, I just briefly want to introduce our Fiona Stanley perioperative program, which we began collecting patients last week. We're seeing current and recent ex-smokers and doing a brief intervention in our pre-admission clinic. We've already collected about 10 patients. We're starting them on nicotine replacement therapy with a patch and pulsatile NRT, and providing intensive follow-up with weekly follow-up from some perioperative nurses who we just got some additional training for, handing over to the ward pharmacists and medical teams, and then post-operatively sending back to the GP or quit line for follow-up. Our program is consistent with international literature showing a 300% improvement in quit rates with this particular model. So watch this space. Thank you.
Very useful. We could see the results of that in a year's time. Thanks very much. So our next speaker is Dr. Joshua Goldblatt. Josh is our advanced training in cardiothoracic surgery at Fiona Stanley Hospital. And, where's your bio here, Josh? And he's going to talk about the implications for smoking cessation on thoracic surgery. Thanks, Josh.
The meeting has been automatically extended.
Fantastic. Well, thank you very much for asking me to. Thank you very much for asking me to speak. There'll be a bit of a crossover on some things with Hamish, just by the nature of our shared specialties in a way. So just some quick epidemiology: that 20% of smoking at the time of surgery, and half of these, 60%, actually continue to smoke. This is just some general literature. Continue to smoke in the post-operative period, despite this very teachable moment with smoking. Now, in terms of perioperative risk, this is all data specific to thoracic surgery, not surgery in general, and resections as well, that there's known to increase costs, worsen quality of life, and increase length of stay, increase post-operative pulmonary complications and general morbidity. And there was a large study in the Annals of Thoracic Surgery in 2009 with about 8,000 patients, were all thoracic resection patients, which showed an increased risk of perioperative mortality in current smokers compared to never smokers. And there was also a risk of mortality that declined, although it didn't reach statistical significance, as the interval of smoking cessation preoperatively increased as well. And similar with perioperative pulmonary complications, which was much higher in current or past smokers, but once again started to decline as the interval of smoking cessation increased prior to surgery as well. The trend to higher perioperative pulmonary complications has also been replicated in another smaller study by Lugg only last year, which basically demonstrated a similar thing. So, touching base, basically, Hamish has already mentioned in terms of quitting preoperatively, there is some talk in the thoracic community in terms of quitting, and some people do suggest that quitting within 4 weeks can lead to increased complications preoperatively, but that's on some pretty flimsy retrospective data, as you can see, by Nakagawa, and I can't pronounce the second name, sorry, but essentially that was quite flimsy and quite small numbers, and that has formed a basis for some care, especially in my experience in Melbourne. However, if you look at the study by Mason et al., it found no correlation between increased post-operative complications and a short duration of smoking cessation. That's a much larger cohort of patients, and I think really that any time pre-operatively smoking cessation is quite important. Smoking and wound healing is known to decrease tissue oxygenation and attenuates the inflammatory healing response. It also impairs the proliferative response and healing response of fibroblast migration, and therefore downregulates collagen synthesis and the deposition within the wounds, and therefore delays wound healing in the surgical setting, and also increases the risk of perioperative wound infections as well. Stopping smoking reverses this inflammatory cell response impairment within 4 weeks, so it's quite important from that point of view. Tissue oxygenation improves almost immediately. An interesting study looked at thoracic patients only in 2011, and actually looked at their quality of life post-thoracic resection, which I think is something that's quite I certainly under-recognise that thoracic resection has a significant impact on patients' quality of life going forwards, even patients with reasonable preoperative lung function prior to the operation. They found that current smokers did not return to their baseline quality of life at 12 months, and they also had, and following on what Hamish said, significantly more pain compared to their baseline. So I think that's quite important. People that were recent ex-smokers, although they had, not unsurprisingly, worse quality of life at 3 months compared to never smokers, this actually did improve within the 12 months. So it showed that it was quite important from that point of view. Long-term survival, well, you've got secondary risks here. So people that smoke obviously have an increased risk of death regardless of having lung cancer alone. But there are some studies that have demonstrated improved prognosis in ex-smokers post-thoracic resection, and this was a study by Nia in, I can't remember when, but not too long ago, within the last 10 years, that was basically showed that there was a worsened prognosis in patients who continued to smoke post-lobectomy. And a meta-analysis by Parsons 2010 essentially showed a recurrence risk, a hazard ratio of 1.86, which is quite significant, and increased risk of all-cause mortality, which is really going to incorporate all the other causes, but 2.94. So continuing smoking has a serious effect on long-term survival. Now, I just wanted to touch base, and I went to a fantastic seminar at, this is my last slide, at Peter McCallum last year, talking about prehabilitation and its role in thoracic surgery. And I really think this is going to be the new standard of care for thoracic surgery, and probably cancer surgery in general. But basically, incorporating prehabilitation in the setting of smoking cessation has turned potentially inoperable patients into operable patients, and I think it really is quite important. One study showed improvement of 2.8 mils per kilogram per minute of VO2 max, and then these patients then subsequently underwent an operation or were previously deemed inoperable on their VO2 max alone, with a 0% mortality, a relatively high morbidity, but essentially they ended up getting what would be considered standard of care for their surgery. So I think that's something going forwards, it's going to be very important, incorporating that. Okay. Thank you.
Thanks to Josh and Hamish. And that, most of our patients, we remember, do not get to go to see Hamish and Josh. And I think it's about 19 to 20% of our patients are actually unable to undergo surgery, though they might see Hamish before their bronchoscopy, their EBIS staging and diagnostic bronchoscopy. So the vast majority of our patients in clinical practice, 80%, are of advanced inoperable stage at the time of diagnosis. And this is where they come to meet our other colleagues, who may also be involved post-surgery and with trimodality therapy. But our next speaker, that leads into Sam Boyer's talk. I'd like to introduce Dr. Sam Boyer, who's my colleague who's recently moved to Sir Charles Gardner Hospital. She's a medical oncologist, and she's going to talk about the implications of smoking cessation in the context of chemotherapy for lung cancer patients. Thanks, Sam. I'll just get your talk up. Thanks.
Okay, thanks again for asking me to come and speak tonight. So from our perspective, as Josh has talked about, there's evidence supporting better prognostic outcomes for patients with early stage lung cancer who give up smoking, and also the secondary preventative benefit. But essentially that's not the primary population that I see. And Annette touched on this about some challenges of addressing smoking in clinic. This is probably clinician issues such as lack of support, lack of knowledge on how to address it, and essentially lack of time. And generally when smoking is brought up, it's in that new patient consult where you're addressing prognosis, treatment, side effects. There's a lot of information for patients to take on board. So what is the optimal time in the patient journey with us to address this? And often patients and relatives have a fairly nihilistic perspective. The damage is already done. I'm here getting treatment for lung cancer. How is this going to improve my quality of life? This is a stressful time. Stopping smoking, I just can't do it. So prognosis and treatment intent. The majority of my patients that I would see would have stage 4 non-small cell lung cancer, but there will be a small proportion with stage 3 disease where we're essentially aiming for curative intent treatment. But if we look at this Framingham Heart study, for patients giving up smoking, it takes 5 years for their risk of a secondary malignancy to drop. So are my patients going to live long enough to reap this benefit? And even with stage 3 patients, that might only be a quarter to a third of patients. So in terms of the advanced setting, I was quite surprised how much, there was pretty limited evidence in this specific population for the benefits of smoking cessation. I'm just going to present a couple of studies that I found with the largest number of patients. It doesn't compare to Josh's thousands of patients. I thought 300, that was about as big as it got for these studies. This was a retrospective study that was presented at World Lung in 2015. And essentially, they retrospectively reviewed whether patients were able to give up smoking prior to initiation of chemotherapy. And they actually found that the median survival was improved by 6 months in those patients who did give up smoking. In terms of an intervention study, this was a prospective study in a similar number of patients, about 300 patients. And what they did is they contacted patients who had a history of smoking within the last 30 days and did a telephone initiation for smoking cessation advice. And there was more than half of these patients had more advanced disease with stage 3 and 4 disease. And in terms of survival, the hazard ratio for death was much improved in the patients who'd managed to quit smoking by about 80%. And this equated to a median improvement in survival of about 9 months in this patient group. To put a more controversial slant on it, the benefits of smoking. We don't just treat patients with chemotherapy now, and immunotherapy is an evolving field in the treatment of cancer. We use immunotherapy in the second-line treatment of advanced non-small cell lung cancer, and there is long-term data demonstrating that smokers actually have better responses and more durable responses to these therapies. And this was just a first-line immunotherapy study just recently published, looking at combination drugs, nivolumab and ipilimumab. And essentially to get into this study, you had to have a high tumour mutational burden. And essentially that equates to being a smoker or being a former smoker. And these patients did better with first-line immunotherapy than with standard chemotherapy. So as Annette said, I've only recently moved to Sir Charles Gardner Hospital, so finding my feet, I said, okay, I'm doing this talk, so what services are available? And it seemed like not very much. And our deference seems to be that we assume the respiratory physicians have dealt with it, and we depend on our cancer nurse coordinators to address this with patients. And in terms of the FDA recommendation for the 5As, we're certainly lacking in assisting patients and arranging things for them to move forward with their smoking cessation. But our CNCs do undergo a mandatory online training. They complete the Fagerstrom assessment for nicotine dependence, and then it's then referred on to the GP and the Department of Health website for them to get some more information. So I don't think we're probably taking it to the next level. And unfortunately, we're not lucky to have a smoking cessation service available at Charlie's currently. So what are the risks in our population for not addressing smoking cessation? Well, really, the goals of care are to optimise cure rates, improve overall survival outcomes, and maximise resilience in our vulnerable population. And I think assisting patients in stopping smoking is part and parcel of optimising outcomes for patients too.
Thank you, Sam. Our next speaker is Dr. Sean Bitter. He's also from Sir Charles Gairdner Hospital. Sean is a radiation oncologist, and we'll talk about the implications of smoking cessation and radiation treatment.
You go.
Sorry, I haven't done my job as chair. Escape again. Here we go, and then we just click on that. There we go. Thanks, Sean.
Thanks. So thank you for that. Now, radiation oncologists often keep a very low profile, especially me. So I do want to give a brief description of radiotherapy, and this is how I explain it to these two. I simply show them this video and explain I use a machine that causes microwaves to accelerate a stream of electrons close to the speed of light before bending this with magnets to crash into a metal target, producing megavoltage photons that are precisely directed to cancers to target DNA of malignant cells. I wish they said this. Unfortunately, they don't, and that's one reason that I make them do German dancing, even though we're not German. So radiotherapy for lung cancers is used for non-small cell and small cell lung cancer. It can be combined with chemotherapy. Our patients, as you can imagine, are often older and sicker than surgical patients. Radiotherapy might be palliative or curative. It can be used in the lung, but also for metastatic disease. So this simple diagram just show we fit in both the curative and palliative treatments. And of course, patients can move between these different streams. Traditional radical courses of radiotherapy are 6 to 7 weeks of Monday to Friday treatment, but palliative courses, for example, a bone metastasis, might be as short as 1 day. There's been a bit of a revolution in radiotherapy for early but inoperable non-small cell lung cancer. We can use what we call stereotactic body radiotherapy. And for very selected cases, these treatments can be given in 3 to 5 doses. And one way of doing this is the CyberKnife robotic radiosurgery system. I apologise, I had to put this in, it's part of my job. But this is the best photo I have. We've got one of these at Charlie's, and the thing that's great about it is that it can actually track the tumour as people breathe. So there's some infrared monitors and some X-ray monitors. So it's set up so while the tumour moves as people breathe, this robot will track with it. And we use it to deliver about 100 to 200 beams from different directions. I'm taking questions about the CyberKnife at the end. Right, so I do hear doctors and patients say it's too late to worry about stopping smoking. I've already got lung cancer. So is that true? So there's just a handful of papers I just want to talk about. So this was a quality of life study with about 1,000 respondents. And what they found is that a number of symptoms and overall quality of life were worse for persistent smokers compared to never smokers. And the patients that managed to give up, so the former smokers, were halfway in between those. We talked about limited small cell lung cancer treated with chemoradiotherapy. In this study, again, smaller numbers than either of the two speakers before me, but you can see that there's a 5-month median survival difference in the patients who stopped smoking. The reason I talked about stereotactic body radiotherapy is we've got this great treatment. There's an Australasian trial that shows it's twice as good as our traditional radiotherapy. But what about the importance of stopping smoking? And this study just shows that there's at least this group of patients, there was a 9% difference in your 2-year survival rate. So just like Annette showed at the start, there have been some surveys. This is one looking at ANZ radiation and medical oncologists, about 300 respondents. 70% of them advised smoking cessation routinely, and this is across the board, so this is not just lung cancer specialists, but patients that, or the whole group of radiation and medical oncologists, but the majority believed they needed more training in stopping smoking interventions. And just giving up smoking can be scary for patients, but I hope I've convinced you that that doesn't mean we shouldn't try.
Thank you.
Okay, thank you.
And our last local speaker is Dr. Kieran Bradley, who is a palliative care consultant at Bethesda Hospital and is also the clinical lead for palliative care for the Tumour Collaborative and the WA Cancer and Palliative Care Network. So welcome, Kieran. I'll just get your talk there. Thank you.
Thanks very much for inviting me. So I wanted to talk about why smoking cessation is important. What I knew was that the speakers before me probably would have covered all the really important data, so I haven't focused particularly on that. From the point of view of palliative care, I think there's a feeling that palliative care happens right at the end of life, but there's growing evidence that palliative care should be involved much earlier on, and hence the benefits of smoking cessation, as discussed previously, are really important. That's quality of life, survival, all of the things previously discussed. What we look at doing is really assessing whether the patient has time to benefit from smoking cessation and whether they're going to be undergoing treatments that will benefit from them stopping smoking, like radiotherapy, chemotherapy, immunotherapy. So from our patient point of view, what are the risks of not addressing smoking? So we miss out on the benefits that have already been so well discussed. Really importantly for our patients, they miss out on the option of home oxygen because if they're still smoking, they can't receive it, and that's a really big thing for a lot of patients from a quality of life point of view. From an inpatient point of view, so working at Bethesda, smoking has issues because from a safety point of view, we have to lock our doors at night time. We're a tiny hospital. We can't have the patients going out at night. So from 5 o'clock in the afternoon to 8 o'clock in the morning, the patients can't go out to smoke. And actually that has huge implications for a lot of smokers if they can't get out to smoke. And we like to pre-warn patients when we get a referral that that's the case. The other issue is if they do go down to smoke, they have to go down into the garden, and then there's a safety issue from the point of them being down by themselves in the garden unless they have family members or we have volunteers that can go with them. The other thing is the risk of withdrawal right at the end of life when people are no longer physically able to smoke, and that's something we are very acutely aware of, and that's probably where we do a lot more active intervention from the point of view of nicotine replacement therapy, and I'll discuss that a little bit in a minute. The other risk of smoking cessation is obviously to the family members, and that sort of feeling that it might be too late for the patient, but it's not too late for their family members, and particularly if they're mostly in the house and aren't well enough to get out, then it has even more implications from a secondhand smoking point of view on their family. Okay, so from a palliative care point of view, what's currently happening? We're always balancing that sort of quality of life issue of the benefits of quitting smoking versus the benefits to the patients of continuing smoking. We always do ask about a smoking history and will follow up with patients if they're interested in quitting. Nicotine patches would be our first line therapy from a nicotine replacement point of view, just because they're really practical going through to the end of life in that they can be in place when the patient can no longer do anything active themselves. What we do, as I've already said, is we'll often look at smoking reduction rather than cessation, really from a practical point of view. And we also need to consider how much fatigue will impact on the patient's ability to do any kind of smoking cessation program, so we bear that in mind. Okay, so there are a few positives to also be a little bit controversial. We find in an inpatient setting, smokers bond beautifully. They're in a little garden down by themselves by the river, looking at the view, and they really build quite strong relationships. And that, I think, is a really positive thing at the end of life, and the family members as well. I certainly find clinically when patients are getting towards the end of their life, and that's that population of our patients, that I'm pretty sure that it makes them live longer if they have to get out of bed and go downstairs to the garden to smoke. Non-smokers tend to take to the bed and don't get out, whereas smokers are determined right till kind of days before they actually die that they're going to get out of bed and go into the fresh air. So, fresh air, I suppose. And I think it's also the other thing to bear in mind is that degree of comfort that smoking provides, particularly at the end of life when everything else is out of their control, that they get something that they have control over. So that's really it. So in summary, we'll always look at assess the patient's quality of life and look at the bigger picture of what length of life we think they have left. We'll always support smoking cessation, but also practically it's more often looking at reduction. We acknowledge the benefits of the cessation, but also look at the risks, if we don't, of what happens at the end of life. The risk of terminal agitation is quite high if you suddenly withdraw from your cigarettes. Thank you.
Thank you to all our local speakers. It gives an overview of kind of patient's journey through many different members of the team. So now I'd like to invite Emma Dean, who is our keynote speaker tonight. Emma holds the position of the acting population health and health promotion coordinator and lead pharmacist smoke-free within Alfred Health. She has over 15 years experience working in the Victorian health sector, including roles spanning leadership, population health, research and pharmacy. And she's been integral in driving the multidisciplinary system change to ensure the effective management of nicotine dependency at Alfred Health and more recently across Victoria, and she's been invited to speak all around the country. So please welcome Emma. She wouldn't me go too long on her bio, but we're lucky to have her with us today. Thanks very much, Emma. Ooh, I think I've done something naughty here. Hold on. I'll just go down.
Yeah, we'll get there.
There we go.
Awesome.
Thank you.
All right, thanks heaps for having me. This is going to be a bit of a kind of mesh presentation because I wasn't sure what to really focus on within the 20 minutes because we've had a very long and challenging journey at Alfred Health in this space. So I just wanted to start that I have no conflicts of interest. I'm not funded by the pharmaceutical industry, particularly around medications for smoking cessation. So a lot of this has already been discussed, but I think it's really important to remember that when we're looking at supporting people to quit smoking, particularly in the early stages of diagnosis with cancer, we're looking at improving prognosis, but we're also looking at decreasing their risks from respiratory or other cardiovascular disease that's attributable to smoking. And certainly there are some populations, particularly those with head and neck cancers, where quitting smoking can really make some significant differences, looking at prognosis and so forth. So what is the relevance? Well, when we look at smoking cessation and cancer treatment, certainly we know that smokers do experience increased adverse effects from treatment. So the adverse effects that they experience can be prolonged and can be more significant. There can also be reduction in the effectiveness of treatment, whether it be chemotherapy or radiation therapy. And Hamish has talked a little bit about, I suppose, the pharmacokinetic and the pharmacodynamic interactions that exist with the polyhydrocarbons in tobacco smoke, which can affect, chemotherapy drugs, particularly around reducing or improving drug clearance, delivery, toxicity, and so forth. And also there's that risk of cancer recurrence or secondary cancers developing, the increased risks of surgeries that have been articulated beautifully, and that reduction in quality of life. So for our clients and for our patients, there stands to be a whole lot of benefits for smoking cessation. So there's been a little bit of discussion already about nicotine dependence, but I like to tell a story of really poor performance at Alfred Health because we tend to be the health service that always talks about great performance. But back in 2008, we actually went smoke-free as an organisation. So this was prior to any legislation being in effect in Victoria. We had a CEO at the time that was all about doing things super quick, to the extent where we actually called her Nike, because she just said, get on and just do it. So she actually gave us 3 months to go from having designated smoking areas throughout all our campuses to actually having no designated smoking areas and a completely smoke-free policy in place. Our focus at that point was around reducing exposure to passive smoke. It was around public leadership. So there's no surprises that that particular initiative and that particular approach didn't do a whole lot. So we actually still had a whole lot of clients and staff smoking on site, and a couple of years later, not surprisingly, we actually had a patient within our inpatient mental health facility. She was involuntary, take Alfred Health to VCAT, citing an infringement of her human right to not be able to smoke whilst an involuntary mental health consumer. It was really a point that was pivotal for our organisation. We had a different CEO at this time. We were looking at reintroducing designated smoking areas. We were looking at going back on our policy. But we had a really strong lead role, who was my predecessor, Kirsten Corbin, who really challenged our executive and our board subcommittee to really stand up for what we had done and to go through this legal challenge. So what was really interesting was that there was no human right to smoke. Human rights only extend as far as that they don't impact on other people. And obviously with the risks of passive smoking, smoking is not going to be one that was particularly protected. But what was really interesting that came out of this, it wasn't okay for a health service to have a smoke-free environment and to force people into withdrawal and to not adequately manage their nicotine dependency. So this consumer actually came on board with us for several years and worked with us on our approach to smoke-free, particularly within our mental health setting. So we actually measured our performance at this time, and only 14% of patients were being asked about their smoking, and only 1% of that 14% were offered any support to quit, which was pathetic. You know, we see 110,000 patients every year that are inpatients. Our smoking rate's about 20%, so it just really wasn't good enough. So when we came to looking at what we should do as an organisation in smoking, we needed to frame it differently. We needed our clinicians to buy in, and that's why we talk about what we call the clinical management of nicotine dependency. It had to sound clinical, otherwise it just became a public health problem, an OH&S issue. It really needed to sound clinical so our clinicians engage with it. So a lot of the work that we've done within the organisation is really bringing nicotine dependence up there as a chronic medical condition where people need to be asked about their smoking. They need to be assisted to quit, and they need to be re-engaged, because in a lot of cases people will relapse, go back to smoking and so forth. So well and truly we have an example where we under-recognised it as a health service, and we under-recognised the relevance of health professionals. And I challenge organisations to think about where we actually screen for this within our medical records. And still in some Victorian health services it'll sit in the social history, it'll sit as a lifestyle in the lifestyle section, and we're not bringing it up to where it really belongs, that it is a clinical issue. It is relevant in the acute setting for us to manage, and it's also relevant obviously for preventing chronic disease. Just like any medical condition, assessment's important, and there's a really easy way to do it. So the abbreviated Fagerstrom score or the heaviness of smoking index. It was important for us as an organisation to ensure that the way that we were asking our clinicians to assess dependence was super easy. We didn't want the process to be long-winded. We didn't want it to be cumbersome. It had to be evidence-based but easy to do. So we use this tool here. And we're actually starting to look now whether we can simplify this even more and just use time to first cigarette as the most, as the one indicator for really starting to understand dependence. So I just wanted to touch on nicotine for a second, particularly the elimination of it, because I think, certainly from my experience, this is one area of medicine, particularly within the Victorian health sector, where we think a one-size-fits-all approach exists. And we don't apply that to any other area of medicine. And I think when we think about how nicotine works in the body, its half-life and how it gets eliminated, it brings up that, hey, actually we should be using things like nicotine replacement therapy and titrating to clinical response. Sounds normal, sounds like what we do, but we just don't see it as often as I'd like to. So nicotine has a really short half-life, super important to remember, because people will seek to smoke to top up their nicotine levels, to replenish those levels. And when you think about people who smoke, it makes sense, because most of the time they're having a ciggy every hour or so, sometimes more frequently. And it's because the nicotine's not hanging around in the body for very long at all. And it's rapidly and extensively metabolised through the liver, and there's also a small element of glucuronidation as well. We know that there's really big variability in how people metabolise nicotine. We know that women metabolise it faster than men. We know that women who take the oral contraceptive pill metabolise it even quicker, and we know that pregnancy is even faster again. So really, clinically, when we think about it, people who metabolise it slower will generally have lower dependence, smoke fewer cigarettes and respond better to treatment than those who have that higher level of dependence. And there's also genetic differences in both the CYP and the UGT activity. So again, there is not going to be a one-size-fits-all approach. And it really still bothers me that the way that these products are marketed in Australia, where you have, a box of nicotine patches and it says, if you smoke more than 10 cigarettes a day, you use 1 patch a day. You could smoke 10, but you could smoke 40. So there's no real, advice for the consumer around what they should be actually using. So I think there stands to be a whole lot of work done both with consumers and health professionals about what actually best practice of these medications looks like. And I think it's also important for us to think about what happens when a patient goes into withdrawal. So the symptoms will begin within hours of quitting or within hours of being put into a health service where you can't smoke. And it's quite interestingly that a lot of the time I'll see clinicians say, I don't think now's the right time to talk to the patient about smoking, I'll wait 2 or 3 days. I say, 2 or 3 days down the track, they've actually peaked. The withdrawal's peaked. It peaks about day 1, day 2. So we've really thrown them into the midst of it by not broaching it as soon as they come into hospital. And that initial conversation with them might be about what we call coping while being in a smoke-free health service. And then as their health improves, morph into a conversation around, okay, well, what do you think about long-term cessation? You haven't smoked for the last 2 days, that's amazing. What can we do to support this? Also important to recognise, a lot of the time as clinicians, we love to reach for drugs to fix problems, and certainly nicotine replacement therapy and the other pharmacotherapies are great for helping with nicotine dependence. But when we think about why people smoke, there's certainly other drivers of their smoking. So how their smoking is related to the behaviours that have built up over many, many years of smoking, and how it's related to their moods and their emotions and so forth. And that's where that behavioural support comes in, whether that's provided by services like Quitline or face-to-face smoking cessation clinics. But it is the combination of medication that's clinically appropriate plus that behavioural support that's going to give us gold standard best practice support for people who smoke. And really, we know that this works in a wide range of settings. We know it works in a wide range of populations. So as clinicians, why would we advocate for anything less than best practice? So it is those combination together is really what we should be going for. So we've done that at Alfred Health. We've embedded an approach for our inpatients. So it was really important for us to do that and make sure that that was systematic, every patient, every time. And we've had some really great success. So not only have we increased the proportion of patients we're actually talking to about their smoking and offering support from 14% to 95%, and that was over a year. So our baseline performance in 2012 was 14%, and we've maintained at 95% and beyond since 2013. But we've actually been able to demonstrate that our inpatients are more than 4 times more likely to be smoke-free than those at a hospital where there is no systematic provision of brief intervention plus pharmacotherapy. So we're roughly seeing anywhere between 15 to 17% of our inpatients being smoke-free at 6 months, which is amazing. We know that there's a couple of settings where we can do a little bit better than this, and this is particularly one piece of research that was actually spearheaded by Professor Paul Miles, our head of anaesthesia at Alfred Health after he was overseas, and he came to us and he said, I want to do something more with smoking cessation in our pre-admission clinic. So we see about 30% of patients who have surgery through the pre-admission clinic service. So we really wanted to introduce something in this space. And so we really just integrated a brief intervention model within the existing interaction. So we have a pharmacist within our pre-admission clinic. So as part of their medication assessment, they would talk to the client about smoking. They would perform a carbon monoxide breath test. they would really highlight the benefits of smoking pre-operatively, particularly relevant to the type of surgery, and they would provide pharmacotherapy at the time of that pre-admission clinic appointment. So we'd have all the options there, and we literally just hand it over to them. We'd give them enough until they were coming in for surgery. So if they were a Cat 2, you know, they'd get a couple of months worth of nicotine replacement therapy. If they were Cat 1, they might get a month or so. They had a referral to smoking cessation behavioural support. So for a lot of these clients, they came through to our outpatient clinic, but there were some clients, particularly those from regional areas, who weren't coming back for their surgery, you know, for 4, 5, 6 weeks, where we linked them into services like Quitline, or we were able to link them into community smoking cessation clinics within their region. So we got some really great results. So these are statistically significant. So we were able to increase the proportion of patients who made a quit attempt prior to surgery from 11% to 53%. So more than half were actually taking on board this advice and actually trying to do something about their smoking. And the number of patients that were smoke-free on the day of surgery increased from 8% to about 23%. And the average time that this cohort was smoke-free was 31 days. Particularly the patients that come through our pre-admission clinic service are generally Cat 1 or Cat 2 patients. So it'd be great to look at, you know, longer term quitting, but for this population, it was just really when they were booked in for their surgery. So I've talked a little bit about our outpatient clinic, so similar to what's been described earlier. So this is an outpatient service that we have at Alfred Health that particularly targets patients that we feel are just not going to be adequately managed in community services. So a lot of these clients have mental illness, a lot of these clients are at risk of social isolation or homelessness. There's also a lot of these clients who have other drug and alcohol substance abuse disorders. So they make up probably about 70% of who we see. And the other 30% are made up by really high-risk surgical patients, patients that are likely to need transplantation in the next kind of 12 months, and also patients who need to qualify for home oxygen. So these patients are provided best practice smoking cessation support. They're provided face-to-face consultations every week or every fortnight for 6 to 12 months. And we've got quit rates of about 42% at the 6-month mark. These are also biochemically verified with carbon monoxide. So intensive support, free pharmacotherapy, but it's a big resource investment into this particular group. Okay, so I think, you know, it's important for us to remember that as health professionals, what we say does resonate with patients, and brief advice does prompt people to quit. And if we're looking at number needed to treat, it's about 1 in 33. So just thinking about you having a conversation with someone about their smoking might only take 30 seconds. So this is not necessarily providing, you know, pharmacotherapy and you providing the behavioural support. This is just a conversation identifying that they smoke and motivating that quit attempt is 1 in 33. So pretty great when you really think about how much time it's taking you. And we know from a lot of research over in the UK that health professional advice still is the greatest external trigger for prompting a quit attempt. And patients expect it. So part of our approach when we went smoke-free is that we actually communicated that publicly and actively. So people were actually querying us if it wasn't happening. And I told the story this morning that there was a 4-bed gen med ward. 3 of the 4 patients were smokers. And one of them was a lady in her 60s. She had COPD. She was spoken to about her smoking. There was a gentleman in his 40s, STEMI. He was also spoken to about his smoking. And then there was a younger patient, overdose, homeless, didn't get asked. And he actually called the gen med physician on it. He pulled the curtain back and said, "Hey, why aren't you asking me? Who are you to make the decision whether or not I want to quit smoking?" And that was a really pivotal moment for that particular ward to start thinking about, well, you know, he's spot on here. We really need to be making sure that we're providing that advice to all patients, no matter who they are. This is just some, I suppose, interesting data around stage of change. And there's certainly quite a lot of discussion within the RACGP expert advisory group that I sit on around the 5A model, and particularly around assessing stage of change and willingness to quit. And this is some data out of Scandinavia, about 1,600 patients. And I think it illustrates the point quite nicely that we should just get on and offer support to everyone and don't even worry about stage of change. So this particular study, 11% of people involved said, yep, I'm ready to quit. 89% said, nah, not interested at all in quitting smoking. But what they actually did was they went on to give best practice support, medication plus behavioural support to both groups. And only half of those who actually wanted to quit took up the offer of support. But interestingly, a quarter of those who said, I am not interested, said, hey, all right, I'll take it. And when you look at abstinence rates, and sure, these are short term, 17 weeks, we've got 37% of the people who were not interested in quitting who are actually smoke-free. And from a population perspective, if we forget about that second group, we're missing a whole lot of people. And that's where most of the people are. So we just get on and offer support regardless. And, people will decline, and I'll just say that's okay, but don't be offended if I ask you again next time I see you, because as your clinician, I really want the best outcome for your surgery, for your respiratory condition, for your cardiovascular function, whatever it might be. I'll just show this one. It's similar data, but this is, again, some data from the UK. Robert West and the team there, they do a smoking toolkit study and pull data every year. And I love being able to show this, particularly to GPs, but I don't think it really matters what profession. I think the concepts resonates with all of us, regardless of what field we work in. So it was 12,000 patients, and they basically looked at an odds ratio for having quit smoking. So the odds ratio for having quit, if you hadn't seen a GP, was 1, so that was kind of our baseline. But what was interesting in this particular study, for those patients who saw their GP, but their GP said nothing to them about their smoking, were less likely to quit smoking than those that hadn't seen their GP at all. And you ask them why, and they say, well, if it was an issue, my GP would have talked to me about it. So it begs kind of the question about how many of us within our practice have a checkbox type of system where we say, do you smoke? Yes. How many? Do you drink? Yes. How much? And we don't actually do anything. So there's this whole idea about not advising may be harmful. So thinking about that within your practice is really important. But you can see here that the final 2 bars, the third one there, when we advised a person to quit, so we said, hey, the best thing you could do for your heart function is to quit smoking. Only a small improvement on those that hadn't seen their GP at all. And again, you ask these people why, and they say, I know I shouldn't smoke, I don't know how to quit. I've tried before. So when you provide that help, and that might not necessarily be you sitting down and providing that behavioural support, it might be you referring them on to a service to be able to do that for you. But that's where we get the biggest bang for our buck. So I just wanted to finish off with a little bit about nicotine replacement therapy. Most of my work, certainly now, is really improving health professionals' capacity around understanding nicotine replacement therapy, certainly across the Victorian health sector. But I think it's important that health professionals, we understand as much as we can about this, because we know that consumers don't understand what they need to know about it to get the best out of it. And the easiest way I explain to patients and consumers about what it does is I say it's a little bit like a cold and flu tablet. It takes the edge off. It makes you feel a little bit better so you can get on with your day. So it reduces the motivation to smoke, it does not eliminate it, and it reduces the severity of withdrawal symptoms. We have 6 formulations available in Australia. So we have a transdermal formulation, so our patches, and then our intermittent products, things like the gum, the lozenge, the mini lozenge, the mouth spray and the inhalator. And we know, as far as do these medicines work, well, it roughly doubles, if not a little bit more, quit rates compared to unassisted quitting. We know safety-wise that nicotine replacement therapy has a minimal addictive potential, and that's got to do with how nicotine is delivered from these particular formulations, which is vastly different to the 30 seconds nicotine to the brain when you have a drag on a cigarette. And we also know that when it comes to side effects in the literature, there's not been any serious side effects reported. And when they do happen, they're usually minor and they're usually formulation related. And I think one of the things that we can take a whole lot of comfort in is that our TGA is actually unregulated unscheduled these medicines. So you can buy them in the supermarket, you can buy them in the pharmacy. So really, when we look at our TGA being a really stringent regulatory body, if they're confident that this is a safe product, they make it available, to be able to purchase unassisted. So I think we can take a whole lot of comfort in really being confident in recommending this to clients, that it'll help them and that it's safe to use. Best results, literature-wise, minimum of 8 weeks. In clinical practice, I would generally use it for 12, if not longer, but I've got some new evidence around that in a couple of slides' time, and I always couple it with that behavioural support, so either in-house through Alfred Health or services like Quitline. And there really are few contraindications associated with NRT use. It's certainly more around precautions in this space. So this is a graph I particularly like to use for our emergency department staff at Alfred Health. So it's adapted from the Royal College of Physicians a couple of decades ago, but I think it illustrates beautifully what we can expect from the formulations on the market in Australia compared to what you would expect from a cigarette. So you can see the pink line, you get really quite decent levels of nicotine in the vicinity of about 22 nanograms per mil within about 10 minutes, so that's your peak effect. And you can see there that the spray, the green one, is the one that gives you the highest peak level within the quickest time, but it's delivering nowhere near as much nicotine as the person would be getting from a cigarette. And when you look at products like the gum, the inhalator and the lozenge, you've got a good half an hour before it reaches its peak effect. And it's only around kind of 7-8 nanograms per mil. It's only about a third of what they're getting from cigarettes. So if I'm a patient and I'm using the nicotine gum and I have no idea how to use it, no one's told me anything, and I expect it to work as quick as a cigarette, to give you the same amount of nicotine as a cigarette, well, I'm going to be pretty annoyed when it doesn't. So clients really need to understand what to expect from these products. And you can see the grey line at the bottom is the patch. Pretty much does nothing for the first few hours. And that would be the case, and I say all the time to our emergency department staff, could you imagine a patient coming in acute pain and we say, here, have a fentanyl patch. That's effectively what we're doing when we're chucking a nicotine patch on them. So then, an hour or two later, they'll often ring and they'll say, oh, I've put a patch on the patient, but they're out the front of the hospital and they've got their IV pole and they're smoking away. I don't understand they've got a patch. And I think it's important to think of the delivery system and whether or not it's going to work for the patient, particularly if they're in acute withdrawal. So what we really know now is best practice, and certainly highly evidenced by the literature and expert opinion, is around what we call combination therapy. So that's the use of a patch plus an intermittent product together. So the patch is providing that steady protection. It's long acting to control baseline cravings, and then they're using the intermittent products to give that quicker and more flexible relief, but still nowhere near as quick as a cigarette. So we encourage patients wherever possible to use these products in anticipation of a smoking trigger. And that's where that behavioural support comes in, because the more they understand their smoking, their triggers and so forth, they're able to use these products preemptively to really achieve those decent nicotine levels, manage their nicotine withdrawal and really allow them to focus on those behavioural and psychological components of why they smoke. So combination therapy has been around for so long overseas. When I worked in the UK in 2005, it was heavily used over there, but we've been a little bit slow to the mark in Australia, and hopefully the next version of the Royal Australian College of GPs guidelines, which will be for all health professionals, not just for those in the general practice sector, and a kind of the unofficial clinical guideline in Australia for smoking cessation, because there are no NHMRC guidelines. I will really look at highlighting combination therapy pretty much as your gold standard for most people who smoke. We also know that there's some evidence around using higher doses. So what I mean by this is using more than one patch at once. So there's modest increases in the Cochrane, Steed and the team in 2012, and there was a study by Carpenter a couple of years ago now showing mixed evidence around it, but it was really quite interesting that these studies only included people with higher dependence, so it didn't include those with moderate dependence. So therefore it might be diminishing the outcomes. But certainly, particularly within our mental health units, we'll often use more than one patch together, particularly to control those baseline cravings, and particularly where it can be difficult to ascertain nicotine withdrawal from, unstable mental health or drug withdrawal, inadequately managed pain and so forth. I have used 3 or 4 patches before in patients smoking 100, 120 cigarettes a day, but we always titrate according to clinical response. So just something to think about. The evidence isn't probably quite as robust, but certainly the approach of titrating to clinical response is our mantra at Alfred Health when it comes to this space. Probably something a little bit more controversial is the idea around using NRT for longer durations. There's been a couple of studies published by Schnoll in 2010 and 2015, but again, evidence around the use of nicotine patches and relapse prevention up to kind of that 6-month mark. Certainly we also know that patients will have their rate of relapses is not as significant in those who are on nicotine replacement therapy products for longer. Not something that we would do standard, but certainly, again, thinking about the patient, thinking about, all their other comorbidities, their social history and so forth, and looking at whether or not we may need to use these products a little bit longer. Kind of my rule of thumb is I don't stop it until I know that they're confident in managing those other behavioural situations and those trigger situations. But some evidence coming out looking at longer duration. There's also the idea around using NRT to reduce cigarette consumption, and I know this has been talked about a little bit here, particularly in those reaching, end of life. And again, there's been a whole lot of literature over many, many years in this space, and it's certainly something that really polarises people, the idea of nicotine replacement therapy for harm reduction. But there is, a couple of studies out there showing that it does effectively achieve sustained reduction over 24 months, and these patients actually had reduced carbon monoxide, and there was some positive influence on cardiovascular risk markers and quality of life, no benefits on lung function. But again, these patients had a positive influence on their motivation to quit, and a lot of them actually went on to make subsequent quit attempts. So just again, I suppose recognising that there is not a one-size-fits-all approach to smoking cessation. Particularly also for those of you working in settings where you can start nicotine replacement therapy prior to a quit date. There is a couple of studies around that. So they actually start nicotine patches 2 weeks before their quit date. And there's been some studies to show that it further increases quit rates by about 35%. And again, it kind of makes sense. The person's confidence that will help them to manage their withdrawal is increased. So for those of you working in outpatients or pre-admission settings, this is certainly something where time isn't quite as critical. They're not having surgery in the next couple of months, where we might be able to look at this type of concept. Certainly for me, where the majority of patients that I would see are inpatients, it's not possible. But again, it's recognising what are the I suppose leverage points we have with these products to really improve consumer acceptability and confidence in them that they can support cessation. So I'm just going to finish off with, I suppose, the barriers that certainly I see all the time with respect to NRT in clinical practice. By far and large, misguided concerns about safety and efficacy undermine the use of NRT. And it's from both health professionals and consumers, and we need to address it. Evidence that NRT products are infrequently used, they're not used correctly, they're used suboptimally or not at all, and I have a really big beef with the consumer medicine information leaflets that currently exist within Australia. We did some research with Vic Health a couple of years ago, and we actually had 87 consumers who were involved in that who pretty much said, I don't understand if evidence is here, why the products are licensed with the TGA here and why the consumer medicine information is here. I don't understand why my health professional is telling me to use combination therapy, but the product information is saying you must just only use patches. So there's this really big divide in Australia around how the products are licensed and what actually best practice is. So part of that project we actually wrote to the TGA, but didn't get a whole lot of response. Also wrote to the sponsors as well of the drug companies in Australia. Compliance is really poor across the board, especially in pregnancy. So people don't use enough and they don't use it for long enough. And we know some data, and we've known it for 7 or 8 years now, that if smokers are addressed with the actual correct information on how to use these products correctly and what dose to use them, approximately half of them that were misinformed say that they would be more likely to use it again. So again, we're just not there where we need to be as clinicians to be really providing that best practice support and that best practice advice to our clients. Just ending up with drug interactions. Again, this is a way for us as clinicians to really understand how relevant smoking cessation is within our clinical practice. We know that there's both pharmacokinetic and pharmacodynamic interactions with smoking cessation, and it's really important for us to recognise particularly those pharmacokinetic reactions where when you smoke you induce your CYP enzyme system and you'll metabolise drugs a whole lot quicker, and there's a couple of examples now. So when people quit smoking, the opposite happens. The liver system no longer works as quickly and we may need to look at dose reduction. So there's a couple of examples there, particularly for the cancer setting, but also antipsychotics, warfarin are really big pharmacokinetic interactions as well. So again, as health professionals, we need to look at the whole picture around if we're supporting smoking cessation, what it means for the patient in the other aspects of their health. That is a crash course from me. My details are there at any point. More than happy to help. We've got a whole team of tobacco treatment specialists at Alfred Health, and more than happy to share anything that might be of use to you guys. Thanks. So I don't know if you guys have all heard, but it's great that the PBS will soon be adding nicotine gum and nicotine lozenge to the PBS. It will only be listed as a monotherapy, which is a little bit disappointing, but they've actually put in their recommendation that they know that that's not best practice and is against current clinical guidelines, but need cost effectiveness data. So certainly there's a whole group of us in the eastern part of Australia looking to supporting that cost effectiveness data to get those products up there as PBS listing. So you're right, that they do come as a cost to the patient. So nicotine patches are obviously available on the PBS. Patients are entitled to 1 course per calendar year, except for Aboriginal and Torres Strait Islander groups, which are entitled to 2 courses. Bit frustrating because people relapse, obviously access can be limited. The other products are over the counter, so they do come at a cost for the patient pretty much in every scenario except for if a patient smokes chop tobacco. The cost of combination therapy comes out less than continuing to smoke. So for those of you that haven't heard of chop tobacco, it's pretty much the unregulated tobacco that you just buy in a little plastic bag from anyone really who's selling it. So it is unpreserved, it is unregulated, not taxed, so it's substantially cheaper to the consumer but comes with a whole lot of risks because it isn't regulated and preserved and treated in the same way.
Caitlin.
Oh, that's okay.
Sorry. You talked about the outpatient clinic that are for high risk people, and you talked about the inpatient setting. But do you have guidelines for your outpatient setting? Because we've gone smoke-free at all hospital sites, but there's no outpatient guidelines.
So guideline for access for support or?
Everything.
Yeah.
So inpatient is really clear, even though it might be
Implemented, yep.
Outpatient, that's not.
Yeah, so I suppose our policy and guideline is for all patients, regardless of what part of their journey that they're at, whether they're a day patient, an inpatient or an outpatient. But our next piece of work is really looking at embedding brief intervention within all our outpatient settings. So we have some clinics that do it fantastically. We have some where there's definitely room for improvement. So we're now looking, we've done well in the inpatient setting, we've nailed the pre-admission setting, it's now looking at our outpatient settings and really rallying accompanying those clinicians in part of that journey. But we hope to be able to replicate what we've done in those settings as well. Yep.
So, are you doing like education for all staff?
Yep. So our approach to education is really quite wide. So we really use the channels within our organisation that already exist. So for our nursing staff, it's a whole lot of online learning. So most just because of the sheer number of the workforce, I think we have 6,000 nurses. So face-to-face education is just not going to be suitable in that space. So we use online learning platforms. We will do face-to-face education with the clinical nurse educators because we've got them based on every ward where they can influence and provide further education. We build it within our HMO and registrar and even basic physician training education, and we utilise the opportunity, of grand rounds and so forth for that broader health professional kind of education. Allied health, we use the education models that they have in place. So really it's quite a broad approach, but the key for us was to have the education for it be the same as everything else. We didn't want people to think, oh God, the smoking people, they're making us do, education that's different to everything else. For us, it was having the same process. We wanted it to be aligned with managing whatever else it might be in the clinical setting.
A comment there, maybe we should make it part of mandatory training for healthcare professionals.
Yep.
Is it compulsory?
We have to do
It is, yep.
our
And
lifting and our...
manual handling and, yep. And I think I didn't talk about it in this presentation, but it's been on a couple of the others that we've had today, is that we know now a whole lot of information about the risk of nicotine withdrawal and the link with clinical aggression. And that's very topical for us in Victoria because of the unfortunate incidents where we had our cardiothoracic surgeon who was assaulted and unfortunately passed away. But what we know from the literature, and we're in the middle of a huge retrospective audit of 1,300 episodes of clinical aggression at Alfred Health to really start unpacking what those modifiable risk factors are for episodes of clinical aggression. And one that's kind of come out already in the interim analysis is patients in nicotine withdrawal. And we know that we can treat that, we can prevent that, and we can minimise that, obviously with the focus of improving patient outcomes and decreasing staff safety. So I think that can be a real leverage point for an organisation because we obviously, there's a huge emphasis on occupational risk, and we know that nicotine withdrawal is a really strong predictor of patients experiencing clinical aggression.
Thank you. I just want to open up a question perhaps to other panel members. Focusing on cancer now, this is a broad system-wide. I think it'll be a while in WA before our hospitals perhaps take on the experience of the Alfred and when that could be implemented. I think that would be the aim though. In the interim, looking at the clinic that you started, Z1 and Hamish, the pre-admission clinic, and on the patient's cancer journey, I want to play with the ideas of how can we better improve our smoking cessation if it's in our cancer patients. And we know that our anaesthesia have taken the lead going for surgery, but in oncology treatments and perhaps with respiratory, it's more difficult to talk about smoking cessation. And what Z1's found is that there's not a lot of referrals to the clinic. And then I've heard of something in the literature, and I've read about it. It's called the opt-out strategy. And I'm just wondering, have you any of you heard of the opt-out strategy, where every patient who's identified, and this could be started in a small way in the cancer journey, perhaps, rather than a hospital-wide system at this stage. Anyone who attends for lung cancer, say, this is just a strategy, who's identified as a current smoker is automatically referred to a smoking cessation clinic as part of their treatment plan. It's an automatic thing, and they have to opt out, so they go really, really don't. But I've certainly found in my experience, this is more of a comment, but to Z1 is that a lot of the patients I try and refer to say, oh look, not blood at this time, and then they come on and see Sam, and they come on and see Sean. Sam and Sean, in the oncology world, when you see patients, do you actively talk about smoking cessation or refer for smoking cessation strategy?
So a smoking history is definitely taken. And I would say to patients, it will benefit you from giving up smoking. There is evidence to suggest that you'll live longer if you give up smoking, but to be honest, I think that's where it gets left. And even canvassing my colleagues as to what happens, and you can say refer, but to refer where? There is no service at Sir Charles Gardner Hospital, and even when I asked the respiratory physicians, they were like, well, we've got quick packs. That was the solution. So there's not something embedded, there's not a service that we can refer to. So one question I wanted to ask you, Z1, is how has this service come about, and how can we set up something similar at Sir Charles Gardner?
I guess start with a bit of passion. I guess you need a nurse, and I'm quite happy to share the tool that I use. I didn't attend any official training in smoking cessation, but I've attended seminars like this, and I've done lots of online learning and done lots of readings of the recent articles. And I started off not quite so confident, but as I went, I was okay. And a carbon monoxide monitor is a good tool, as a lot of people really see it visual. So if you have anyone, I'm happy to have your person for.
Do you know where the funding is coming from? Essentially that's often the quintessential point, isn't it? How it comes from.
Because Hamish has also started the smoking cessation preoperative.
We have adopted an opt-out approach.
Is it opt-out?
Yeah, opt-out essentially. So we will take all referrals. We'll refer all of our smokers to our perioperative nurses who do the smoking cessation counselling. Even if they don't accept the quit pack to start with, we'll ring them in 3 or 4 days' time and say, hey, have you had a chance to think about it? And they can definitively opt out then if they want to. But just to speak briefly about setting up something with no funding, we've done that essentially. So we identified some resources that we had. We had some pain nurses that we've utilised as smoking cessation nurses. Speaking of no funding, we wanted $7,000 to run a smoking cessation course for them. And we had to pay for it out of our own coffee money in the end. But we did it, and we've set it up, and now these nurses are confident, they're accepting referrals as well. It helps that 2 of them are ex-smokers as well, so they've got a bit more perspective, particularly in the opt-out approach as well. So.
And I suppose the challenge is then for each of us in our specialties, until our hospitals develop a broader approach, is we have something in respiratory at one place, we've got anaesthesia and pre-admission, is that all of us, look, we've got cancer nurse, clinical cancer nurse coordinators or clinical oncology coordinators embedded in your teams. We've got Dora Wang at Fiona Stanley, who's a fantastic nurse, clinical nurse. I
think one of the things we did is we invited all the CNCs along to our training as well. So we had Dora along, we had the colorectal nurse, we had the upper GI nurse as well. So they all have those skills that our nurses have got as well, and did a 2-day comprehensive package. So I think we've got a little backup behind the house as well.
Yeah, and we have to start from the bottom up, because this is where it begins. And while Emma and our other colleagues work from the top down, so I think more questions, comments from the audience. But please, Kelly.
I think for Josh. So I have a more optimistic view, because Emma will be speaking to the WACS operational managers tomorrow, and mainly South Metro senior executive staff.
Right.
So tomorrow,
I might be sick.
By the end of the day, tomorrow Emma will have convinced a system-wide approach to addressing smoking in hospitals. But I guess I just want your advice on how some of those statistics you were talking about in terms of benefits for smoking cessation around how do they translate to short-term savings for hospitals? So when Emma's showing her last slide tomorrow, what are the big things that people like that will want to hear in terms of health savings, and what are those really big examples of immediate?
Take an example of a patient with head and neck cancer who's had half their face taken off, a bit of their fibula and skin popped up on their face. They have a very high rate of that flap failing de novo, irrespective of smoking status. Smoking increases that likelihood. If that flap fails, they go back to theatre, they go back to ICU for another couple of days, they spend an extra 2-3 weeks in hospital. So that's $200,000, $400,000 for that one patient. So that's pretty significant, I think. The length of stay has definitely increased for patients who get complications, wound complications, cardiovascular complications. And that's probably, I think, the most substantial inpatient cost for those patients, not to mention quality of life, comfort, all that sort of stuff as well, which is a little bit intangible. But in terms of dollars and cents, I think if you talk about the risk of complications, the risk of prolonged inpatient stay, prolonged ICU stay, increased complication, increased intervention, increased return to theatre rates, all of those things I think are very easy to calculate. And certainly we could do a cost calculation pretty quickly about that.
There's Josh and Hamish there to talk about that.
Do you get pushback from that though? Because we used to get pushback in, or not so much at Alfred Health, but at other health services saying, well, we're activity funded. So actually the more activity we generate, the more money we get.
Yeah, we've got a cap on activity though, so there's an absolute maximum activity and we're already at it.
Okay.
So
for your...
maybe next year we can get more activity-based funding, but not this year.
Yeah, so we have, I suppose, similar type of thing with our WEAST funding, but there are some organisations that are under the cap. So for them, they don't stand to benefit at all. But I think that the argument is relevant. But it's just, it can sometimes be for those health services that actually are well and truly under their cap, and they just push back and say, well, we're not funded for prevention, we're funded for activity, we treat disease, illness and injury. So it can be certainly a challenge in the Victorian sector. I'm not sure how relevant that is to all health services. Whereas we find the arguments that you talked about really relevant for our surgeons, particularly those who are really competitive with each other around, complication rates. So we're actually really able to utilise that to our advantage within our sector. I had a question. So did you have to pay for the pharmacotherapy yourselves?
Yeah, so we're only able to give PBS scripts for the patients. I put in a submission to get hospital subsidised, and we subsidise for inpatients, but for the outpatients that was precluded essentially.
Yep.
I would love to push that again, because I think being able to give someone something in their hand to take home would be really valuable. But
Z1, can you tell us
Z1's,
what have you been able to get for your patients?
Yeah, I'm quite lucky to have a small stock of nicotine patches. So if they were go on like nicotine therapy, then I give them a pack as a start pack and a script. So I say, this is how you put them on today.
Yeah.
Yep. Because when they walk out with a script, and they might just leave it.
So I think it's 8:40 now. Any more questions from the floor? Yes, at the back. Lovely, we'll make.
I was thinking that this program would include patients who had cancer of the bladder.
Absolutely.
The connection between smoking and later developing cancer of the bladder. So perhaps the urologists would be excited to do something similar to get stats you have done. Stop smoking and stay stopped and reduce their complications, if in fact it does make a difference, which we won't know until the trial.
I think there's a fair bit of data with bladder cancer and reduction and improvements in outcomes, just as there is for lung, I think, from my reading.
Yep, so we have an opt-out approach for every patient that needs a cystectomy, so our urology team blanket referral to our service. But I think I'd love to see an opt-out approach across the board. I think our service would struggle. We have about 120 patients at any point on our list, current patients, and we operate 4 days a week. But certainly, I think we've also got to utilise the telephone and the state services that we have at our disposal as well. I mean, for a lot of clients, they will prefer face-to-face consultations, but there is, even at a bare minimum, referral to Quitline that can be done quite easily, and they can facilitate even the pharmacotherapy component of it and working with the primary care providers. So even if that's our default minimum, I think that we can get some really great results. We have our Victorian quitline has quit rates in the vicinity of about 24% in patients using evidence-based pharmacotherapy. So still really great, results to be gained from telephone counselling as well. So I think, remembering that as an option if you've got nothing else, and making that proactive referral rather than giving the patient the number, which in most cases will end up they won't call.
I know the respiratory physician has done that, and you can book the time that you want. It's all done. Yep.
Another question at the back.
These days, a number of young women don't want to stop smoking during pregnancy because they don't want a big baby, particularly and I see in that age group quite freely discuss their feelings on this. So my question, which is part of suggestion, is would it be possible with your groups of patients who do have lung cancer and do smoke, how many of those were born to a mother who smoked during pregnancy? Compared with patients who have lung cancer, don't smoke, how many of those were born to a mother who did smoke during her pregnancy? Because the flow on could be, if the link is a molecular biology aspect, mothers who might be prepared to quit for 9 months, who normally wouldn't do so, might do so if there was this genetic passing on genes that might be exposed to cancer. So it's an academic opportunity to operate.
It's a good point. We struggle to collect even current data and staging data for our lung cancer patients statewide. So I think in an ideal world it'd be great to have all that information. I think it would be quite relevant. I think I'll just wind things up a little bit. It's getting quite late. One more comment from Sam. Sorry, she's been waiting.
Question. It's actually, with lack of funding. Emma, do you have any tips of how best to engage GPs? If we refer someone to nicotine, the helpline, and then, try and then, pass it on to the GP to take control of the prescription and the face-to-face consultations. Have you got any tips for that?
Yeah, so we've done a lot of work with our one of our PHNs, particularly in the Gippsland region of Victoria, because there was basically a mining disaster out there, so the government put a whole lot of resources into that space. But it was an approach where we looked at embedding smoking cessation within primary care within that PHN. And it's quite interesting that we found similar things when we were talking to GPs, lack of time, lack of skills and so forth. So our health services in Victoria also quite often have GP liaisons within the service, so actually involving them in your approach is really important. And as a health service, I suppose, what's the role about improving the capacity of GPs as far as skills and knowledge in that space? So certainly our approach as a leading health service and recognising that crucial interface between tertiary care and primary care. A lot of the work that I do will be with GPs and practice nurses around improving their skill and their knowledge around that space. I think when we're talking about funding, and I don't know whether this is something that's possible within your organisations, but something that really helped us, and look, we were really lucky. We had a top-down approach from our CEO and our board that they wanted this to happen, but we were actually able to engage lots of different parts of the organisation to all contribute a little bit of money. So instead of asking for 10K or 12K from one unit, our pharmacy department would chip in $3,000 for NRT. Our population health team would chip in a couple of thousand. Our anaesthetics department would chip in a couple of thousand. And we did it as a trial, got some really great data, and then put in a business case to the organisation with a consumer voice, so a patient story there as well. And that's how we were able to get a lot of these things operationalised within the budget. I think also the opportunity for grants as well. There's quite a lot that are available. They might, again, only be small amounts of money, but it might be something that's just enough to get you your 3-6 months worth of activity and data. So I think there's funding is a big challenge. I don't think we're ever going to get to the point where people are going to be throwing money at us. So it's a little bit creative how we may need to go around it. But I think if you've got interest from various parts of the organisation, try and ask for a little bit of money from lots of different people, and that can sometimes be helpful.
Great, thank you. Well, I think we'll bring it to an end, everyone. And thank you very much. So I'd just like to close with a quote from Carolyn Dresser, who's one of my favourite speakers. If a targeted therapy were available with similar demonstrable impact on cancer treatment outcomes as smoking cessation, it would be considered negligent not to use it. So that's the kind of impact smoking cessation can have in lung cancer treatment. So I think we need to move ahead, and I've got an idea actually I'll talk about with the panel afterwards. There's a funding proposal, I think we could put something together. So, thank you very much to all our speakers, our local speakers and our speaker from Victoria. Thank you, Emma. And to our Cancer Council for organising the evening. Thank you, Kelly. Okay, I'll bring the evening to a close. Thank you. Thanks, everyone.